Good day, global citizens. Welcome to another episode of Dr. Fajembola'S Opinion. It's an honor to have you all watch from different parts of the world and also leave your encouraging comments on different platforms where this program is posted. Today, I have a very, very good colleague of mine and someone who I would say God honors because when you are humble, God honors you. So someone who is very knowledgeable and very humble, and God really honors everything he does. Before I go into introducing him, I want to say something, and I want to share an experience with you, which I had during the week, and also something which has sparked conversations across different social media platforms. Basically, it's about the service we as global citizens received from health facilities. Now, talking about services, someone outside the health sector might not see a deficiency in the service him or I receives from the health facility, but as a medic, because I know, for example, someone like me or our guests, because we know what should be done, we can see a deficiency in it. But mainly, there are 2 points I want to share. The first point is I discovered when I was pregnant a few months ago that when I went to the hospital, like the consultant, because he knows I'm a doctor, like he's always happy to have me around because then he could invite medical students to come and learn and teach them, because not every patient, even though it's a teaching hospital, because of the environment and also, because of mainly the environment and the type of institution, people don't really allow medical students or residents whatsoever to learn from them. So I see this as an avenue to talk to global citizens. Like in the next 10, 20 years, basically, these are the people who will work on you. These are the consultants you'll be meeting. These are the attendees you'll be seeing. These are the old doctors, because sometimes you want old doctors. These are the old doctors you'll be seeing. So the earlier, the better. The earlier you allow them learn from you and not from ChatGPT, the better doctors they will be. The better their hands-on. So please, when you get to the hospital, whether you are in a teaching hospital or not a teaching hospital, if a doctor asks for your permission for a student to learn, if they can bring them in to show them how they work on you, please allow them, because they're the ones that will work on you and your family, your friends and family in the next 10 years, in the next 20 years. Another point I want to share, I see this as a good platform to share it, is when we go to the hospital, normally, it depends on where you are. Somewhere like New York, even if it's a small hospital, because of the population, you have a large amount of patients, let alone some places in Africa, from places like Kano, Nigeria, where you see even the private hospital, you are seeing lots of patients, let alone a government hospital. So please try to make the work easier for the doctor you are seeing by even though the doctor wants to create rapport, try to make their work easier. Don't say unnecessary things, don't ask unnecessary questions. Like, you understand, even though they want to have all the information, like make the work of the doctor easy. An incident happened a few days ago when I went to the pediatrician with my child. Because I naturally, when I go to see them, I make their work easier. But this time around, something just told me, like, just say something to make her smile. And I could see, because she was already stressed coming in from another patient, I could see, like, when I said the joke, she was like, how are you? How many of you are living at home? I was like, we are just for living at home. And someone else was like, who else? I was like, the angels. The angels. And she laughed so much. So I laughing so much, it made me happy. And I saw the more love she gave to my child, like sense of humor, make life. Medics are not angels. Sometimes why they don't show you sympathy, because they know that you are there to use them. And they're also there. Some of them are there for their money. So when they see that you care about them, they'll give you more care too. to whether you are the patient or to your child or your parents. So those are 2 points I want to share before we start for today. So let me quickly go to what we have for today. Our guest researcher by the name Dr. Kanyike. Dr. Kanyike, how are you doing?
I'm fine. How are you, Azeezat?
I'm good. I'm pushing. We are here, we are there, we're everywhere. Yes. So let me give you a biography before we get to the main talk. Let me say the biography of Dr. Kanyike Andrew Marvin, right?
Yeah,
Dr.
sure.
Andrew is a talented researcher and scientist. He has worked on research initiatives involving COVID-19, diabetes mellitus, and antibiotic resistance with a variety of researchers, both in and outside Uganda. He has written a lot of and co-authored publications in respected international journals, where he has been writing since an undergraduate student at Busitema University in Uganda, where he received a Bachelor in Medicine and Surgery. Also, he has completed lots of international training and won many grants. He currently supports the creation of Natural Products Research and Innovation Center as a member of Busitema University Natural Products and Drug Research Group, which is focused at the Faculty of Health Sciences, Busitema University. Is currently a PhD student who is based in United Kingdom. Is going to tell us what is what is focused on his PhD. So, Mr. Marvin, I say Mr. Marvin, sorry, Dr. Andrew Marvin, please tell us what are you focused on for your PhD?
Thank you so much, Azeezat, and thank you for having me. Yeah, so I'm currently doing the PhD at the University of Exeter in the UK on a multinational project that is in Uganda and Malawi, and we are basically looking at non-overweight type 2 diabetes mellitus patients in sub-Saharan Africa, trying to understand what drives diabetes among these atypical picture of people that we have not been seeing, and probably also trying to interrogate if and whether the management guidelines and interventions that we currently use also help support them manage their diabetes. And all this comes off a backdrop of continuously seeing a growing population of younger and thinner people coming to hospital with diabetes mellitus, as contrasted to a bit of the elderly and more obese people in the Western population. Yeah, so, and most of the guidelines and things we use are really based on research from Western populations that are mostly involving the white and Caucasian races, and we do not have much of information on people in our own settings. So my PhD is on really understanding whether the traditional risk factors that we know, like physical inactivity, poor diet, contribute to non-overweight type 2 diabetes mellitus as it does to obesity-related type 2 diabetes, and also understand how to improve our management guidelines to help these patients better manage their health. Yeah, thank you.
Thank you so much for giving us an elaborate overview of what you're focusing on your PhD. Actually, it's when I came to places like the Global North that I got used to seeing people with MD PhDs and seeing MD PhD as a norm. Like from where I come from, Nigeria, it doesn't matter if your IQ is 200 over 100, like you have to do your master's before going for a PhD. And I also have that intention, like, except if there is a particular course I want to go for my master's, like, you understand. But yeah, when you say there are professors, yeah, who have just MD, and because of their publications, that's why they rose academically. And it's a good thing to see, like it makes life easier. And also yeah, gives you direction as to where you are going to. One thing I personally appreciated. So today we are focusing on hypertension among people living with HIV. So one thing I appreciated when I was doing undergraduate in Uganda is the hands-on in seeing patients with HIV and hypertension first and being able to have enough exposure to give you the knowledge you need and other tropical diseases which were taught in medical school. Currently, population of people with HIV on the continent, we are about 25, we have 25.6 million people as of 2022, and which is 2/3 of the global total of HIV patients. Currently, Uganda's HIV population is at 5.1%, which is roughly about 1.4 million. To what the statistics I got, by the way, you can counter it, which is about 1.4 million people living with HIV in Uganda. So when I read your paper, I appreciated because for me to do medicine, I did my medicine in Kampala, which is the capital of Uganda, but I did spend 1 year in Mbale. Mbale is the eastern part of Uganda. I also spent a good like 2 years of my undergraduate at Masaka, which is also the western part of Uganda, if I'm right.
Southwest, yeah.
Okay. So do you see like will you refer, and I'm not trying to anyway minimize Uganda in any way sincerely, will you see Mbale as an urban setting, like a city or rural setting? Because I saw you were like rural, urban, you were using a lot of in the paper, you and others were using a lot of rural, urban, and I was like, Mbale, sincerely, is Mbale a city? Because to me, if I was asked based on the 1 year I spent, I don't know if you know where IU is in Uganda. Maybe because of my exposure, I don't know. Will you say Mbale is a city?
Yeah, very, very good question with no straight answer because it's really very subjective and it's set by politics rather than how you want to see it because
Okay.
politically in Uganda's structure, Mbale is one of the cities in Uganda. I
Okay.
think I think we have 5 cities. We have Kampala, the capital, Mbale joined that lot, Barara, Gulu, Port Portal, all those now are cities in Uganda. But if you want to look at it on the scale and on a comparison with the known proper cities of the Western world, then you may not actually want to call it a city. But if you're looking at it in the context of the developing Uganda and
Okay.
in the context of in the rural settings in our country versus the urban settings and the growing cities and the kind of lifestyle and way of life and standard of living, then it really qualifies to be a city because there is sort of a delineation between the way of life, the style, and everything within this urban area, Mbale City, compared to the really rural areas of Uganda.
Okay. Thank you so much for giving that explanation. For someone who has never been to Uganda and they're reading the paper, they get the outlook of what you and other authors are trying to explain. So my first question for you, there'll be other discussions I'll bring up in between the questions, but the first question I have for you is being a doctor, because I know you've done your, will I call it residence or internship? You've done your internship, you've worked
Mm,
in Uganda, you have a good work experience. Let me not say elaborate. You have a good work
mm.
experience working as a medic in Uganda. How do you feel? Because one of the problems I face as a medical student is the patients not buying the drugs. And even my senior colleagues have been stressed by that. Sometimes patients not being able, because I was taken to the regional hospitals where you have hands-on and many patients, the rural setting, let me put it that way. So how do you feel sometimes, because not all, how do you feel sometimes when your patient can't afford a certain medication?
Yeah, thank you. And of course, that is very frustrating. And just like so many other developing countries, the whole system is still struggling in Uganda, or is not all that best, though there are quite a number of improvements that go on thereby. But still, people, especially in the rural areas that are a bit impoverished and deprived, find challenges and find it hard to meet some of these healthcare costs. And even when they come to these public health facilities that ideally are free or are supposed to be free, but they are not entirely free because most of the times and sometimes the logistics are not in and you have to buy them. They find it really hard to make their way through the treatment and management plans. And it even becomes worse with increasing non-communicable diseases because they're a bit expensive to manage. And you have this patient that needs to do all this panel of chemistries, the liver function test, the renal function test. You need them probably to do a Doppler scan. You need them to do a CT scan, and almost all your management largely is hinging on determining what is really coming out of these results. But you can't proceed because you do not have them. And you can't blame the patient because actually they don't have the economic means to make it happen. So most of the times it delays decisions in the management because if you asked for such a test today, the patient may have to mobilize themselves, the family, the resources. And if you asked it on a Monday, they'll probably do it on a Friday and probably also do half the pan of the tests you want. And that is very frustrating because it affects the decisions you're making rather than doing the objective standard kind of medical practice that you would want to, the one that you learned from the book, from school, and you end up improvising and you have to find your way out to help this patient at the end of the day, all the panel of things that you ask them to do. So yeah, that's where we are. But I think with improvements and growth into the health system, things like insurance coming in, probably that would be a history, especially if we get a good national health insurance policy. Yeah.
Thank you so much, Dr. Marvin. Actually, I commend the government of Uganda for in as much as the economy is compared to all African economies, we are thriving, we are developing in terms of HIV. I commend the government of Uganda for what they are doing because when I was there, they would give money, they would give food to encourage HIV patients to come and take their medications. Uganda has stable electricity compared to a country like Nigeria. I'm not trying to insult Nigeria, but compared to Nigeria, there are some services and other things that Ugandans have. So I commend the government of Uganda in that aspect, making life a bit easier for their, making life a bit easier. Let me not sugarcoat, a bit easier for their citizens. And also, I also want to commend international organizations like the World Health Organization and other local and international NGOs working towards universal health coverage, trying to make sure health services are accessible and also affordable for global citizens. So when I was in Uganda as a student, we assist and other things. During surgeries, there is a likelihood, no matter if you are using your goggles, your what are they calling it, your surgical wear, whatsoever, there are likelihoods of blood spillage during surgery. I've experienced it many times, and one thing I'm grateful to God is I left Uganda because there is no, when you say you are working on patients, sometimes 5 out of the 10 patients you have have hepatitis or HIV or a combination of both. You can't say you won't work on them. So you just have to be careful. So one thing I thank God is I graduated from Uganda without having those pillages, or maybe when you are catheterizing, cannulating a patient, injuring yourself, going with HIV or maybe another hepatitis. As a doctor, have you, and when I was here as a medical student, I have interns who were on PEP, and I saw how sometimes the side effects of these medications, how it's like the kind of dreams they are having, how it affects their day, like, and other side effects. You as a doctor, have you ever experienced like those pillages, blood spillages during surgery? And do you have any experience using PEP in treating yourself?
I have not had to use PEP, and I don't know how careful I've been or not, or just lucky, but I've really not had that experience of using PEP, and I don't want to, because the close friends I've had, actually none of them has completed that month. It is hectic. The side effects and all that, and also medics are very poor at taking medication. Actually, we are very poor at that. So yeah, I've luckily not had that, but yeah, there are really very common instances that occur because of the patient loads we usually have. You have a lot of patients to work on, doing this and that. So it's most times easy that you may land into such injuries and incidents, but personally, I've not had that experience.
Okay, I was waiting to hear your no, not I'm negative or pessimistic. I was waiting to know your experience in using PEP and other medications. Dr.
No,
Marvin, in your paper, now let's dive more into into the paper. In the paper, lifestyle related risk factors like poor dietary habits, physical inactivity, obesity were discussed in relation to lifestyle of Ugandans living in the eastern part of Uganda. Which region has the worst lifestyle and how does it show? Which region in Uganda? I know Uganda has many regions. Which region has the worst lifestyle and how does it show in the overall morbidity and mortality? Not in relation to HIV and hypertension now, like generally, lifestyle risk factors in Uganda.
thank you so much. That's quite a bit of hard question to answer, because most of the things are informed by good data capture, which we do not have, just like in many other developing countries. So if you want to talk about all-cause mortality, burden, mobility, for various things, trauma and all that, they really require good registries, like in the hospitals or national registries. They require, very good population studies, but we do not have much of the registries, things like disease registries, whereby you have that longitudinal data that talks to morbidity, mortality, how it has changed over time, where such patients come from, and which regions of the country for different things, trauma, cancer, diabetes, hypertension, which I realize that it has been very fundamental in these countries that are developed, because now it is helping them transition to use of AI, machine learning, and big data, because they have the data, they have collected it over time. And it is easy to ask a question like, how is the morbidity and mortality all cause in the United States? Where is it better and all that? Because this data is there. But in our countries, that is very scarce and something that we are really just waking up to improve with all the implementing partners and all the grants that are really now coming in to strengthen data systems and capture. But nevertheless, it's not all lost, because we have a few of wide population studies, national population studies, like the Uganda Health and Demographic Survey that goes on every 4 years. But we also have a national NCD risk factor survey called the STEP survey, which is done in so many countries across. We had the first one in 2014 and we did another one in 2023. So that gives us a bit of information, maybe like on risk factors like diabetes, hypertension, obesity, physical inactivity, and health diety, where they are occurring and where gender differences and all that. So if it was like speaking to a specific facet of that,
Yeah.
maybe like NCD or risk factors, it would be easy because we have a bit of that national data. But when you look at things like trauma, for example, I only know we have a Kampala trauma registry, so you can get a bit of information about trauma in Kampala. But if you wanted across the country, you may not actually be able to know exactly how's the trauma like in the eastern part. Most of those are in police reports, which come out annually, but it's not out of scientifically rigorously collected data. But having said that, still, if when you look at the distribution, let me say, of these non-communicable diseases like hypertension and diabetes that are common in our country, you see that actually the prevalence is as much in the urban areas as it is in the rural areas, and it has been growing exponentially in either setting. And we have seen actually our rates of hypertension double from about 1.4% where it was nationally in 2014 to about now 2.6% in the last one done in 2023. So in the space of 10 years, that has doubled, and even this could be underestimated because, like I said, the data capture is not good. These are just ones of cross-sectional studies. Yeah, but that's what I can say. It's really hard to talk to a general kind of mortality, morbidity across the country. Yeah.
Thank you so much, Dr. Kanyike. Actually, it's not just Uganda, even across Africa, data is still a huge problem for us, and we are optimistic in the nearest future. Since we're having more data scientists coming out of Africa, such problems will be solved. And because we need such data in even creating proper management for nationals, locals, and also other global citizens, instead of people from the global north coming with the funds to say they want to do a specific research and they go with the data which is not ours or which is not even solid. Them not doing it. We as citizens of that country would carry out the research. So I'm optimistic in the nearest future, such problems will be solved, not just in Uganda, but also in Nigeria and other African countries. From your paper, I got this paragraph from your paper. When I was an undergraduate, to get more exposure on HIV, we were taken to IDI in Makerere University. Shout out to Makerere University for accommodating other universities to their to their research research institute. And one of the things we saw is like there is a specific day allocated to a group of patients. Let's say on Monday, let's say Monday for patients who are married but have other partners, Tuesday maybe for gay, Wednesday for gay and lesbians or something like that. Wednesday, you understand? To the best of my understanding when I was there. If you're at idea and that's not how it is, please tell me if you watch this video and tell me I'm wrong and I'll take the correction. But that was how it was, a day allocated for a group of patients. So from your paper, I understood that eligible participants were recruited using a convenient sampling method from patients attending scheduled appointments on 3 specific days of the week, Monday, Tuesday, and Thursday. Within these convenient samples, participants were randomly selected by choosing their files from those present on these days. Dr. Kanyike, patients were chosen randomly. Would you say from the paper, like specific groups of patients? Because like I said, IDI Monday, Tuesday to Friday are different to the best of my knowledge. And now you chose 3 days, Monday, Tuesday, and Thursday. Do you feel the paper focused on certain groups of HIV patients?
Okay, yeah, that's a very good question. I think the systems are a bit different. Um, you're giving me the experience of IDI. I have personally not rotated there or worked there. But at the HIV clinic at General Referral Hospital where we conducted the study, they, apart from adolescents having a day when they come and maybe patients with HIV, but also hepatitis, generally the entire group of HIV patients are given like the same return dates. And these days we pick this because most of the return dates for these patients
Yeah.
fall those days, but not necessarily predetermined by a particular category or group. Maybe this key population comes on this day, this key population comes on this day. They don't have such an arrangement, but if you take a day like Monday, a day like Thursday, those are high volume days when most of the people come back for their next reviews. And so it would give us a good population if we wanted to sort of have a balanced kind of participant recruitment and also have to choose have that liberty to choose. Otherwise, if the patients are few and you want to randomly choose, sometimes it may be hard to hit your sample size. But yeah, I think that's probably maybe a nice model or not, like to group people and make sure they come on different days. But yeah, it's sort of different from what happens at that hospital in Eastern Uganda.
Okay, thank you so much, Dr. Andrew. It's beautiful to note that I say Masaka, all of them are carrying Masaka and Mbale. They're all it means to note that Mbale Regional Referral Hospital operates differently from the IDI at Makerere University. And I'm sure this method is also what I'm not sure, but I guess that's what also works at Masaka Regional Referral Hospital, where maybe a specific day is not attached to a group of HIV patients. Another question from the paper is I got Dr. Kanyike that similarly 70%, I quote, similarly 70% of people living with HIV in a study from central Uganda were unaware of their hypertensive status. This reflects statistics, of course, of the general population in Uganda, where 82.3% of those with hypertension were not aware of their raised blood pressure from a recent national survey in 2014. This is a huge problem. Most hypertensive participants were unaware of their condition. Dr. Kanyike, 68% is more than half. 68% is a huge statistics, despite being regular patients at the HIV clinic. We're talking about regular patients now. What do you feel? Number one, what do you feel contributed to this? Number two, what are relevant stakeholders doing to reduce the statistics? Because 68% out of HIV patients is at Mbali Regional Referral Hospital. It's a huge statistics. And if we want to copy paste, let's say copy to copy paste. I'm talking about copy paste Bakere and Mbale and Masaka. So what do you have to say about this?
Yeah, that's a good fascinating question. So just as you rightly stated it, if regular patients, like patients who are in regular contact with the health system, actually a huge percentage of them can have hypertension and go unnoticed, how much more for those that are not regular? I think you can, I guess you can imagine how big the problem could be and is in the population. And partly, I would attribute that to the verticalization of the health system, especially in regards to HIV as it has been, but the landscape is changing. That you know, HIV patients, the HIV clinics set apart mainly the procedures about HIV, key performance indicators of the clinic about HIV indicators and outcomes. The health workers are mainly trained and tasked to, you know, meet goals, meet targets, key performance indicators, and you know they have to present nationally, and so, and they're like, oh, the rates of suppression in Ibari are bad, Masaka is doing good. So all the focus would really go on the HIV indicators, and little emphasis will be given to these other conditions. These patients have mental health problems, they have hypertension, they have diabetes, they have other diseases that most of the time go unnoticed because the systems were like vertically arranged. This is a clinic for hypertension, this is a clinic for HIV, this is a clinic for diabetes, you get. And so it would be easy that a patient comes and passes through the system, they assess their adherence. Have you taken the drugs? Okay, the adherence is good. Are you due for viral load? They take off the blood. Have we screened for whatever? Give them the refill and they go home, even without taking their blood pressure or taking their blood sugar. Because we even do not have most of the basic equipment, sometimes find the unit doesn't have a blood pressure machine. Or there was one and the batteries ran out and they never replaced them. And then they don't have a glucometer to take. Yeah, so that I think contributed to the high rates of unawareness. So most of these patients, when they come, the health workers, they don't mind so much to check for these other things. So they go undetected, and you find a very huge population have elevated blood pressures, are unaware. They have elevated blood glucose, and they are unaware. But now with the integrative efforts that are in place, I think that landscape is changing, and I really hope it will change for the better in future. And I think even the USAID cards that have come in have sort of given a push and accelerated those integration efforts, because in the wake of funds cards and no money to facilitate these standalone clinics, then we have to shift these patients and put them into the general primary healthcare setting. And in the general primary healthcare setting, the hope is that all things can be managed comprehensively and holistically. That a patient comes in, all of them are supposed to be assessed for their hypertension, for diabetes. If they take an HIV test and we know whether they are HIV positive, if they have infectious or non-communicable diseases, all can be catered for and managed in one place, like a one-stop shop. So if we go well on that integration strategies and approach, probably we shall reduce on these numbers of people that go unscreened, undiagnosed, unmanaged, and in the end actually get very dire and expensive complications. Yeah.
Thank you so much for speaking elaborately on that, Dr. Kanyike. I so much agree with you. In the next years, paint a picture of hypertensives in Uganda with words. What do you feel in the next years and the next few years? I don't know much about hypertension in Nigeria, but I don't know, for some reason I feel Uganda has better management. Nigeria has no slaughter me. I feel Uganda has better management of HIV. So in the next maybe a decade, how do you see HIV in Uganda? I mean, hypertensives with living with HIV in Uganda.
Yeah, thank you. So with the status quo and everything as is, without much effort, really hypertension may skyrocket through the roof in Uganda in the next 10 years. As I already alluded to earlier, in a space of 10 years, when we have done these two national surveys, the prevalence doubled. And that could even be an underestimate because we do not have quite good regular studies and data. So if we go with the same kind of way of doing things, then we are going to face really a very huge outblown burden of hypertension. But however, If something is done and we improve the screening and we also improve on the health financing that goes to the non-communicable diseases, then things might improve. Because as you may know, and probably as it may be the case in most of other developing countries, most of the funds are still going to the infectious diseases, which we are also still grappling with. Malaria is still a very big killer in Uganda. TB is still killing a lot of people. But in the backyard of this burden of HIV, TB, malaria, the hypertension and diabetes are really cropping up at a very high speed. And in hindsight, we may wake up actually when we have a very bad burden. And the other scary thing is that we thought this used to be in the elderly populations and probably young, but they are now cropping into the young people. So most of the people now who are getting hypertensive and diabetic are young, average age of 35, 30 years, and this is really terrible for a young population. That time when you're supposed to be energetic and contribute most to the economic growth of your country, to start grappling with complications, stroke, poor sight, fatigue, and everything. So, yeah, we really need to do something about it. Otherwise, it will be too bad with the status quo.
Okay, thank you so much, Dr. Kanyike, for shedding more light on that. Do you have a closing statement to those watching us?
Yeah, thank you. My closing statement would be that as we are struggling to improve the health and health systems in our countries, everyone, each individual person should know that they are actually part of this improvement, starting with themselves. Talking to this, especially in the realm of the non-communicable diseases that are silent killers, because these are things that we can prevent, even without spending much of huge resources that would have gone to other things. Just starting with yourself and developing a culture of having a wellness checkup, having the urge to understand about your health, to understand about a better lifestyle you can adapt so that you save yourself from this expensive disease, you save yourself from these debilitating complications, and also in turn save the country and the nation a huge budget on health that could go on other socioeconomic transformation. So everyone has a role to play and everyone should actually mind to check on themselves. How is their blood pressure? How is my blood glucose level? How are my kidneys? How is my eyesight? Things that are really simple, that are very inexpensive, but they can turn out to be hell on earth if at all you get to cross over to the other line. Yeah, thank you.
Thank you so much, Dr. Andrew Marvin Kanyike, for honoring us with your presence. Thank you so much for answering the questions excellently. Most importantly, thank you so much for sharing your expertise with the world. So, global citizens, thank you. Not enough for the thank yous. I guess you're already used to me now. Thank you so much. Thank you so much for joining us on this episode of Dr. Fajembola'S Opinion. We all know the effects of HIV medication on hypertensives. And if one thing that is common, not just in Nigeria and Uganda and other African countries, is having a low viral load and thinking, oh, you're cured of HIV. No, the apps you are taking, the miracle water you're taking, whatsoever you are taking, you feel, aside from hypertensives, you feel is reducing your viral load, which has reduced your viral load, and you strongly feel you've been cured of HIV, is wrong. Please don't think you are cured of HIV. HIV has no cure for now. Your viral load can just be suppressed, and your viral load is suppressed. That does not mean you should have unprotected sex or should expose yourself to other causative factors of HIV. Yes, until you join us on the next episode of Dr. Fajembola'S Opinion. Stay blessed. Watch this episode. Most importantly, please read this paper to have more insight on what we just discussed and what you've just watched.